is that I don't know if everybody was aware of this, but the NOFO, the Notice of Funding Opportunity, came out from the CDC back in, I think it was January or February. It is due to the CDC on March 18th. We had some questions about, Massachusetts had some questions about our eligibility because of the way that some of it was worded around hospitalization rates and stroke mortality. But we did get word back that we were indeed eligible. So that was a very loud sigh of relief from all of us. So we have submitted. I was just saying before everyone else gave it to my internal people today. It is due to the CDC on March 18th, and we will know sometime between June 30th if we are awarded. This is a 3-year grant for the next project cycle. So we will keep you all posted on whether or not we receive funding. Fingers crossed, please, and send out the best wishes to whoever it is you send out best wishes to, and hope that we are awarded, because we really would like to continue our work. With that being said, I'm going to turn this. Oh, one more thing. As you all know, just my confidentiality reminder, even though we're in a virtual space, our confidentiality agreements still hold. Please don't share any information with anyone outside of this call about the anything you learn about including names of facilities that are participating, any data that anybody has presented, that you are all bound by law not to share that. So thank you. And we will do, at the end of this, we'll do also like a quick, any general DPH question and answer after the learning session. Okay, so today's learning session is called The Use of PRESS, P-R-E-S-S, to guide early intervention and rehabilitation therapies among patients with dysphagia post-AIS. Today's presentation is going to be presented by Kate Scales. She is the Stroke Advanced Practice Nurse at the Comprehensive Stroke Center at Tufts Medical Center. She has over a decade of clinical experience. I'm sorry, this is Kate Scales. I may not have said her last name. Sorry about that. She has over a decade of clinical experience as a registered nurse, with most of those years dedicated to the care of patients with stroke and other neurological diseases in the Neurosciences Unit, Neurological Intensive Care Unit, and the Surgical Intensive Care Unit at Beth Israel Deaconess Medical Center. She is also acquiring her master's degree and Master's of Science in Nursing at the University of Massachusetts in Boston. And in 2018, she was recruited to join the leadership team in the Comprehensive Stroke Center at Tufts Medical Center. And besides her clinical services, she is running the high-risk follow-up clinic for their most complicated stroke patients. This is a combined presentation with Tufts and Encompass Rehab. Teresa Hayes is one of the presenters from Encompass Health. She's the business development director at Encompass Health Rehab of New England. She has more than 20 years of experience in post-acute healthcare and has included, among many things, program development and leading the team that assists community members in accessing the acute rehab level of care. She received her undergraduate degree in psychology from the University of South Alabama and a master's degree in social work from Boston College. She is the immediate past president of the board of directors of the Brain Injury Association in Massachusetts, and she's still an active board member. And Dan Parkinson, who is, he's been a PT for 29 years. He is working at Encompass Braintree Rehab Hospital for the last 25 years. He was previously the director of rehab services, and he is currently the director of business development. So it is my privilege to turn this over to that team. Thanks, gang.
Awesome. Thank you so much, Claudine and Susanna, and everybody for having us today. Let me just share my screen with you and get our PowerPoint up and running. I should be like a pro at this point. Now that all we do is have PowerPoint presentations. But here we are. So thank you. Like I said, thank you so much for having us. My name is Kate. I think I have met a lot of you or know a lot of the names. And as Claudine said, we originally actually did name this that long name with press, and you'll notice I've changed the title a little as Dan, Teresa, and I were working on this and going over it with the rest of our team. We got to thinking like, yes, I am going to tell you about this tool called Press that we use. But really the story that we want to share with you is about how we came together as multiple sites, as an acute care site and a post-acute care site. And within both of those sites, multiple departments and specialties to come together and develop in a coordinated and evidence-based fashion different pathways to be able to offer the most evidence-based advanced care to our patients. I am apparently not creative, and I don't have a good acronym for that, something we can work on. So we settled upon right care, right place, and right time, which I think really summarizes what you'll find when you hear our story. And so Teresa, Dan, and I are we work together well. We're going to kind of tag team this as we go along. But as Claudine said, we're happy to answer any questions at the end, or if there's anything, please don't hesitate. So what we're going to talk about today, a quick overview. I want to share with you kind of the background of our project, a little bit about the history of dysphagia, taking a step back, and then kind of walk you through our quality improvement process, and how we develop a project, how we then work, and what steps we took to make this project a reality. I will talk to you a little bit about the PRESS, that predictive tool that we mentioned, and then again focus really back on the collaborations that the Encompass Rehab Hospitals and Tufts Medical Center formed to be able to create this process, and how we then implemented it. Give you a little bit of information about the data so far we have, and then kind of talk about the next steps and what we're working on next with this. So, as I said, what was developed was a clinical collaboration between Tufts Medical Center, our stroke center, and the Encompass Rehabilitation Hospitals. A little bit about Tufts Medical Center for everybody. We are a 415-bed tertiary care center in the heart of Boston, located right down in Chinatown. We're a university-affiliated and academic medical center. We are a Joint Commission certified comprehensive stroke center, so we are thrombectomy capable. We also participate in the Coverdell stroke program, obviously, because we're here, which is fabulous. On average, we care for about 350 patients per year with an acute stroke as their primary diagnosis. That number has increased over the years, and in addition to those primary patients, we do have a stroke consult service and probably take care of another 500 to 600 patients with stroke throughout the medical center during the year. We do, of the academic medical centers in the greater Boston area, have one of the highest case mix indexes. We're also part of the WellForce network, which means that we work closely with Melrose Wakefield, with Lowell. Our neurology department is affiliated with the Framingham Metro West Neurology, so we see a lot of patients from there, as well as down from south of Boston in Region 5. And what this does is this it brings a unique and diverse population to our center, patients of all ages and strokes of all different types. So a little bit about the Encompass rehab facilities.
So thanks, Kate. Encompass Health Rehabilitation Hospital of New England and Encompass Health Rehabilitation Hospital of Braintree, we actually have 5 inpatient rehabilitation hospital campuses surrounding Boston. The two larger campuses are in Braintree and Woburn. We also have campuses in Framingham, Lowell, and Beverly. Again, all 5 hospitals are inpatient rehabilitation, and our stroke programs are all, and all 5 campuses are disease-specific certified through the Joint Commission, meaning that we have the programmatic model that we follow for performance improvement and evidence-based treatment interventions for stroke. Last year, in 2020, combined New England Rehab and Braintree Rehab cared for 1,300 stroke patients in the inpatient rehabilitation setting. Thanks, Kate.
Yeah. So I want to tell you a little bit more about our relationship with Encompass. And I think even before this project developed, it really started way back in 2018. And really the initial start of our relationship was centered around our goal, both of our mutual goal to provide excellent care across the continuum of stroke. Dr. Lester Lung and Dr. Lester Lung is our stroke director, and we work really closely together to manage our stroke program. And as we were really developing and preparing our program, one thing that we truly believe in is making sure that our patients, as I think all of us do here, otherwise we wouldn't be here at these meetings, but we believe in quality care across the continuum. So making sure that we're helping and support and working with our pre-hospital and our post-hospital providers so that we can make sure that our patients are receiving the best care possible at all stages. And so part of that for us was thinking, where do our patients go when they leave the hospital. We recommend that they go to rehab. We know that a strong stroke neurological rehab program is going to be the best thing for our patients when they require that, when they're not able to go home. But what is available in our area, and where are we sending them, and what programs are we offering? And when we're counseling our patients, we want to be able to counsel them firsthand. And so a really important thing to us was first just reaching out and meeting with Dan and Teresa and actually going to the Encompass hospitals. So Lester and I were fortunate enough to go and tour a couple of the hospitals in Woburn and in Braintree, and really meet with not only just Dan and Teresa, but the entire team there, their other leadership team members, their neurology stroke providers, their therapists, their PT, OT, speech and language. We saw them in action. We saw the gyms. And I think, we were able to also share our philosophies with them and introduce ourselves so that it's not just a name, that we have faces to the names, and that we really can strengthen and reinforce that we're a team working together to be able to help our patients. And like I said, we really just wanted to know where they went and what that process looked like. And so that was kind of the groundwork and the base layer for our relationship. And then fast forward a little to actually one of these Department of Public Health meetings. I think, if I'm remembering correctly, Dan, we were actually at BMC for one of our meetings, and Dan and I were partnered at the same table working on a fishbone diagram. And we were like, we work really well together. What can we work on? Like, this is great. We do think a acute and post-acute hospital collaboration would be something that would be awesome, but what can we work on, and what do we want to work on? And so that's where the quality assessment and performance improvement project and opportunity comes into play. And I think we all remember from nursing school or grad school or whatever school, the plan, do, study, act, idea, and the PDSA cycle, and asking those questions so that we can start to form. And that's exactly what we did. So, Dan and I at first started off like, what are we trying to accomplish? We're trying to accomplish an acute hospital and a post-acute hospital project. How can we loop Teresa into this as well and bring in more people? And then what is a change, and what is a possible change that we can make that affects both of our centers or all of our centers? What can we measure? What project can we do that's goal-driven, data-driven, and is multidisciplinary? And so we use these 3 questions here, you see, to help guide and start our PDSA cycle and eventually come up with our plan. Before I dive into that plan, part of what makes this plan and help develop this was just thinking a little bit about dysphagia and kind of the clinical context and natural history of it. And I know we're all very aware, I'm sure, I think the dysphagia screen and that quality metric is probably a thorn in a lot of our sides. But dysphagia so obviously is something that's very relevant for our stroke patients. It can affect up to 50% of stroke patients or more, depending on the papers you look at. So it's a very common complication. As we all know, it can be associated with an increased risk of aspiration pneumonia, often leads to increased length of stay, both in the hospital and in a post-acute setting. Can lead to decreased quality of life, poorer nutrition, and ultimately increased morbidity and mortality. In terms of recovery from dysphagia, I think one way that has been helpful for me, and one way we can think about it, is that in general, recovery of dysphagia happens in thirds. So in general, based on the natural history that we know of dysphagia, about a third of patients will recover their ability to swallow within 7 days. Another third, it's going to take them a little longer. They'll probably recover somewhere between 7 and 30 days. And then that last third of patients will most likely have prolonged dysphagia. So it's going to last more than 30 days after the onset of their stroke symptoms. And so how can we use that information to better guide our nutritional recommendations and means of nutrition and support for our patients? And until recently, there wasn't an evidence-based prediction tool. This was kind of just something, we know the natural history, but how can we use that in an evidence-based way to concretely shape the way that we treat and manage and recommend treatment options for our patient? Without that predictive tool, too, it made it hard for our rehab colleagues, as Dan and Teresa will tell you, to be able to accept patients with alternate means of nutrition. It's a big ask. And, I think as stroke coordinators, and nurses, we, historically would say, oh, if they can't swallow, either they get a PEG tube, or unfortunately, they're not going to be able to go to rehab. We weren't able to send patients with DABOS if that was their, or NG tubes if that was their sole means of nutrition, because there were a lot of barriers, and it wasn't, a safe discharge plan. On the same side, how can we, if there's patients that we do think are going to have longer swallowing courses and take more than 30 days to recover, and ultimately would benefit from a PEG tube and an earlier PEG tube placement, how can we, where's the evidence to support that, or a way to say, yes, you know what, we think we should move towards a sooner thing. And so that's where this evidence-based predictive tool ended up being developed, and really came and made this helpful, and has given us a new project and new ways to be able to gauge this. So looking at our quality assurance process improvement plan here at Tufts was kind of where we first started. We started brainstorming, we heard about this predictive tool that I'll tell you about, and we thought, how can we make this into a project? And so like all comprehensive centers, we have a number of quality projects that we work on each year as part of our multidisciplinary stroke code council. And so, like I said, internally, we said, what are some areas we can work on? Okay, we know dysphagia is a big thing. We think people probably have an increased length of stay when they have dysphagia. Historically, we know that. So how can we potentially reduce their length of stay? And by reducing their length of stay, how can we get them possibly to rehab sooner, so that acute rehab can start sooner, and hopefully they'll be able to benefit from it sooner? And also spend less time in the hospital. So hopefully decreasing cost for both patients and for the hospital, reducing exposure to infections and other hospital-acquired complications, pressure ulcers, aspiration pneumonia, UTIs, those other infections, and things that patients are more at risk for. And kind of the third goal would be, how can we improve the selection of patients for a gastrostomy tube? As I mentioned, some patients ultimately will need one, but how can we easier or more evidence-based identify who those patients are and who would benefit from that? So with any quality improvement project, I think the first thing is we look at goals, and then we have to think about, what are some issues? What are some possible issues that may come up or that already have come up, and that we can try and overcome as we're building this project. And so the first one, obviously, was previously there was a lack of an evidence-based tool in order to help us predict dysphagia. I think anytime you have multiple groups and disciplines working together, there's always the potential for communication issues. There's a lot of teams that are involved, even just within an acute care setting, thinking about stroke patients, and then specifically about stroke patients with dysphagia. Speech and language pathology, our inpatient neurology team, our nursing staff, our case managers are a big part of this too, as they're trying to help us figure out what the best next step for our patients are, and help counseling our patients on what that feeding plan should be. Limited surgical availability, both as an inpatient and an outpatient. How do we figure out our availability for surgical interventions if needed, and figure out the timing for that? How can we possibly schedule an outpatient PEG and not interfere with our rehab days, get it done in a timely manner? And then on the inpatient side, how can we, like I've said, anticipate the needs for a PEG surgery early enough that we're able to get that done and get those patients to rehab still within a timely fashion? Oh, I'm so sorry. Got a little trigger happy with the mouse. And then I think, the other question is just how do we make those pathways possible? How do we get patients to be able to safely be discharged to a rehab facility, and have us be supportive of these rehab facilities that are willing to work with us, so that we can make this as successful as possible? And so in gathering our kind of pre-data, we took a look at here, this is data from 2019, taking a look at our stroke patients as a baseline. So you'll see we looked at patients who admitted with an acute ischemic stroke, who failed their initial nursing dysphagia screen versus who passed. And you can see here the blue columns are those who failed their initial dysphagia screen. And in general, most of the time, the length of stay is significantly longer than for those patients who failed. And so this supported the research that's out there and the evidence that this is a thing. And so next comes our prediction tool that we talked about. Fortunately, one was developed. So this is the press score that we mentioned. This was published originally in JAMA in 2019. It was a study done in Switzerland, and as part of this study, they developed and validated a tool to predict swallowing recovery after acute ischemic stroke, and that was called the PRESS, or the Predictive Swallowing Score. And so what is that? So the predictive swallowing score is a prognostic model. It helps us predict the recovery of functional swallowing after ischemic stroke by indicating the probability of impaired oral intake and the chance of recovery or return to a pre-stroke diet at 2 time points, after 7 days and after 30 days. So again, going back to that 1/3, 1/3, 1/3, this helps guide that historical course of dysphagia. With this information, it helps us stratify patients into treatment categories and decision making. So based on this information, kind of can help us stratify into two groups initially. One, that low to intermediate risk of prolonged dysphagia. So those patients who fall into a category of it's going to take them more than 7 days probably to regain their swallowing, but less than 30 days, and possibly they would benefit from either having an NG tube or DAW off and continuing on to rehab and having continued speech and language, intensive speech and language therapy for their swallowing, versus a second group, a high risk group, a group that's based on this score likely to have continued dysphagia past that 30 days. And really, in that case, then they would probably benefit from an early PEG tube placement 3-4 days after stroke versus waiting another week, 7-10 days, having them sit in the hospital, hoping that their swallowing improves, but ultimately we end up at the same place and having them have a PEG tube. I think the other part where this score can be very helpful is for facilitating conversation. So both with our families and patients, as well as with our other care providers. So using an evidence-based tool, the conversation might sound a lot different and can help. So, Mrs. Smith, I'm really sorry that your mom is still having trouble swallowing. Based on this score, though, I think that her swallowing is actually likely to improve within 7 days, or within, after 7 days, before 30 days. And so based on that, I think it would be a great plan for her to go to one of our rehab hospitals, have temporary swallowing in place, and then continue to work on her intensive therapy versus when we're counseling about a PEG tube placement, we can use this to help us, Mr. Smith, I'm really sorry your grandfather still is having trouble swallowing from his stroke. And based on this score and this information, I think it's actually going to take him a while to recover that, probably more than a month. And so I think he would actually benefit from having a PEG tube placed. It's a more semi-permanent method of nutrition, but that will allow him to be able to move to the next stages more quickly, get to rehab sooner, prevent some of those hospital-acquired complications that we know can happen, and start on that next stage and be able to receive adequate nutrition and recovery. So it's really, I think, great at helping provide more information to our patients and to their families about what their feeding plan could look like, as well as to other clinicians, to our surgery teams that we're going to tell you a little bit more how we worked with, but to be able to say to them, we're using an evidence-based tool to be able to predict and have this information and say to you, I really do think a PEG tube needs to be placed. And this is why. It's not going to be something that you place today and tomorrow all of a sudden they can swallow again. We're like, ooh, sorry, we misgauged that one. This is, and certainly that can still happen, but this is hopefully providing a little bit more information and making it a little bit easier to make that prediction. One thing too that I think is really important takeaway that we, in part to our clinicians who are using this though, is that this is one tool. This is one part of the equation, and like any score or any clinical prediction tool, an ICH score, even an NIH stroke scale, these are one tool, one possible thing that can help predict. But we want to make sure that we're looking at the whole picture. We're looking at the patient as a full patient and taking all things into account. So letting this help guide us, but not this being the sole deciding factor on everything. Taking a look at the score in particular, it's based on a couple different things. So it's based on the patient's age, their NIH stroke scale and admission, their stroke location, whether or not the infarct area involves the frontal operculum or not. And then 2 assessments that are done by our SLP colleagues, the risk of aspiration of the NE2 scale and an impairment of oral intake, or an FOIS, which has to do more with their diet. Are they NPO? Are they on a modified diet? And as part of this research project from Switzerland, not only did they create this tool, but they also created an app for our phones that can make it a little bit easier for our care teams to access. So I'm going to show you that too. So this is a paper version of the press calc, and it contains the various parts as I told you, looking at the age, and it scores, assigns points to them based on that information, the ranges of the NIH stroke scale. This is the area of infarct, whether or not that's part of the frontal operculum or not. So these gray shaded in areas, depending on the cut and the modality of MRI or CT that you're looking at. The risk of the SLP evaluations, the initial risk of aspiration, so things, signs of aspiration, as well as I said, their impairment of oral intake. So what level of diet are they on? And you would complete each one of these and fill this out, and you would get a total score of 0 to 10, which then can be used to help us decide as I said, what is the likelihood that they're going to regain their swallowing ability and what that time frame may be. And so what the smartphone app, thank goodness for smartphones and for apps, what would we do without them? Forget paper in addition. This makes it really easy for us. You can all download this too. It's out there. You put in basically all that information and it calculates and totals for you that score and gives you those percentages I mentioned. So it gives you the probability of impaired oral intake at 7 and 30 days, as well as the probability that they will not return to their pre-stroke diet at day 7 and day 30. In terms of eligibility for using this press calc and this score, it's validated for use in patients with ischemic stroke, so not hemorrhagic stroke. Patients with hemorrhagic stroke, as we know, tend to have a different trajectory for their recovery, and so this wouldn't quite apply, and this wouldn't be able to be translated directly to them. It should not be used in patients with existing dysphagia. So if someone has dysphagia either from a prior stroke or from a history of throat cancer or other various things, unfortunately, this can't be used. It also can't be used in patients with recurrent stroke within the predicted time frame, meaning if someone has a second stroke within that same 30 days and has dysphagia from that, it really shouldn't be used, as well as patients who present later. So you can see this here in that list up there. Taking a next step, while that score, like I said, is really important, I think the thing that Dan and Teresa and I really want to impart and focus on today is really the collaboration and how we came together to take this tool and make it into a project and hopefully improve the outcome of our patients. And so the first step in any good collaboration is finding a partner, identifying someone that you think you can work together with, and then figuring out what it is that you can work on. And so we felt like we found that in Encompass Rehab Hospitals. And as Dan mentioned, the Encompass Rehab Hospitals they have multiple locations. They have acute stroke rehabilitation programs that we felt were offering the highest quality of rehab to our patients. They're also Joint Commission certified. So it was a natural collaboration and a natural partner that we found. And any collaboration or quality improvement process, there's a couple different things that once you find that partner need to be discussed and sit down. And so we kind of came together in a group and started brainstorming once we knew we wanted to work together. And so we originally started some informal brainstorming around June 2019. And one of the first things that we did was identify who are our stakeholders going to be, both here at Tufts as well as in Encompass. And so some stakeholders we identified would be our stroke center leadership, myself, Lester, any other neurologists here at Tufts, as well as hospital leadership, so that we knew that they were buying into this program with us and would be there to support us. Our surgical leadership partners, our acute care surgery, as well as our ED leadership partners, as I'm going to tell you a little bit about where ED and surgery kind of came in and really played a big part in this, as well as people at Encompass, so our Encompass leadership. And then, of course, you can't have a dysphagia project without speech and language pathology, at both centers and sites, as well as, of course, our nursing staff and the people that are on the front lines, the on-call or inpatient neurology teams, the outpatient neurology teams at Encompass, as well as our case managers, really the case managers and the Encompass liaisons, those bridge between the acute care setting and the post-acute care setting who get our patients there. And so, like I said, we came together, we started brainstorming and coming up with things. And as within any project, one of the first things that we had to think about were what are some potential concerns or limitations? How can we identify these, anticipate these, and then prevent them from happening? So I'm going to have Dan and Teresa talk to you a little bit about some of those.
Yeah, so when Lester and Kate first, when we sat at the table with them for the first time, and we started talking about dysphagia and patients with impaired swallowing and getting them to rehab earlier, we had a lot of buy-in for that, but we knew that historically there's always been concerns about having patients come with NG tubes, and so the first thing we needed to do is identify what were those concerns. Why were we concerned about having a patient come? Because clearly we were able to manage the NG tube. What we really realized is that the concerns were what happens when the NG tube pulls out, or we have concerns like that. What happens on the back end if a person doesn't meet the functional gain that they would be predicted to make, and we needed to look at an alternate mode for nutrition, hydration, and medication management. So we really identified that medication management, hydration, and nutrition were important for obviously, and we needed to make sure we could have pathways that would help us to manage that if the what ifs happen. And that would be, patient comes and they start to really increase their mobility with us in rehabilitation. The likelihood of the NG2 being dislodged or pulled out totally increases significantly. We knew that we had to look at our own sort of clinical competencies for reinsertion. And we wanted to make sure that there were, and Kate's going to talk about it more, but we had to make sure that there were pathways. We didn't know that in the beginning, but as we were talking and going back and forth and sort of talking about our concerns, we realized that perhaps we needed a pathway to help us in the event that we weren't able to reinsert it ourselves successfully, but we didn't want to go down the road of a G-tube placement yet. We needed to make sure that we had pathways, or we had alternatives, or we understood that if it did pull out in the middle of the night, how do we make it so there is alternative modes or to administer medications so that we weren't missing doses and stuff in case we needed to take care of the reinsertion at a more reasonable hour of the day. And then finally, again, to that patient that just didn't make the gains that we would predict that they would using all of the clinical information that we had. And in the past, historically, this was a real problem for post-acute providers, and still remains in many cases where, no one really owned from a surgical standpoint, whether it was interventional radiology or surgery or, whoever it was that was doing, peg placements at the particular hospital. And so we really needed to think about that what if. And that's when we went into, the idea of creating these pathways. And I'll turn it back over to Kate to talk you through what we came up with.
Thanks, Dan. And I think, to one of Dan's points with the concerns of limitations, one thing that as we were coming together, and I would suggest that other people when forming a project like this think is, we knew concerns and issues were out there and there would be barriers, but it was never, the question was, how can we overcome these and work together to make this possible and really lean into these issues and figure out solutions for them. And so that led, as Dan said, to our pathways and our guidelines, which we're going to go over. So taking a look kind of at the next step, though, would be our treatment thresholds. How do we decide who falls into what treatment threshold? And so you can see here the points refer to the points that are assigned the total of the PRESS score. So as I said, between 1 and 10. And then the percentages here are the probability of impaired oral intake at 7 days and at 30 days. Again, from that PRESS score, so based on their NIH, their SLP evaluations, etc. And so again, thinking about those scores and our historical trajectory of a third for the different groups based on the duration of their dysphagia, we sat down together as first as a TUFS group, and then as we went our separate ways. We said, you guys think about some thresholds, we're going to think about some thresholds, and then let's come together and make sure that we're kind of in line with what we're thinking. And so this is kind of what we came up as a project, or as a starting point, that patients that are falling into these high categories, these 9 and 10 scores, where it's really, really unlikely that they're going to have any swallowing ability at 7 days, and probably pretty unlikely that they're going to swallow at 30 days. This is a group that we would recommend early PEG tube for. We would advocate for having that PEG tube placed as soon as possible during their acute hospitalization. And then kind of really the rest of the group that, everyone 8 and under and falls into this group of, they would probably benefit from having an NG tube, going to a rehabilitation hospital, continuing monitoring, continuing treatment, because they're more likely to just take a little longer and then hopefully regain their swallowing. But rather than, as we did previously, have them wait at the hospital, continue to monitor them here, we can get them out of here sooner and get them to that rehab. I think in terms of a lower threshold, there isn't necessarily one. Certainly, some of these really low points, these 1 and 2, I think those are patients where we want to think, and depending on what other workup is needed for that stroke patient, it might make sense for them to be, or they're going to be in the hospital anyways for 4 or 5 days. And so we're able to send them to rehab without an NG tube, but still kind of taking that into account and trying to plan as soon as possible for whatever outcome ends up being the best treatment plan for them. And so, as we said, with our limitations, we created a couple different pathways. The first one would be a return to ED for NG tube replacement pathway. So as Dan mentioned, a big concern is what happens if that NG tube or dob off becomes dislodged or clogged? How can we get this fixed and get them back as soon as possible? What is the best way for them to come quickly to our emergency department for replacement without avoiding hospital admission and avoid hopefully losing any time or much time at rehab? So this was set up as a fallback, as a safety measure. In order to do this, we collaborated with our ED, nursing, and physician leadership and developed this plan. And so here at Tufts, we have a system called In Quicker. It's essentially a scheduling system for our emergency department. And so what a patient can do is, this is a patient, they're discharged to rehab, they're continuing their SLP evaluation, and then say, by accident, their tube gets dislodged a little bit. Certainly, the team at Encompass can try and replace it or try and problem solve it. But if for some reason they can't, the next day, assuming that the patient's stable, they can go to our In Quicker and schedule an appointment. So rather than coming to the hospital and showing up in the emergency department and not knowing at all, there's a STEMI and a trauma and another stroke coming in and potentially sitting in triage for a few hours waiting to be seen, they can schedule that and say, okay, we have an appointment for your tube to be replaced at 10 a.m. So we'll schedule our ambulance at 9 a.m. And as part of this, developing this system and the use of In Quicker, we came up with a specific template, a worded template that the rehab facilities could plug into the online In Quicker, schedule that appointment, and indicate to the emergency room staff, we have a patient with an NG tube had a stroke, they're participating in this program, we'd like to schedule them for a replacement. Like I said, that allows for us to schedule transportation and have a plan rather than just showing up. And the goal we set with our emergency department was to have these patients return to rehab. So time that they leave rehab to the time that they're back at rehab to be 2 hours or less. So they come in, they have their express evaluation, we replace that NG tube and send them back to Encompass so they can continue on and hopefully not miss much of their rehab. The second pathway, that other group, are for those patients that we discharge them with an NG tube. They're doing their intensive therapy 5 days a week, but unfortunately it ends up that they don't progress. They aren't able to progress their swallowing. They're still having trouble, and it looks like they are going to need a more semi-permanent means of nutrition. And so in order to overcome this, we worked with our acute care surgery leadership team here at Tufts and explained the process and set a goal with them. How can we make peg tube placement be a day surgery? How can we get this done as efficiently and safely and quickly as possible so that patients can come and be discharged back to rehab without missing more than a day of rehab, and also for a logistical standpoint, avoid having a hospital readmission so that they're putting possibly their rehab stay and their rehab plan into jeopardy by having that hospital readmission. And so first thing was kind of to figure out what exactly is the trajectory of a stroke patient at an Encompass rehab. And so we sat down with the Encompass team and they looked at their data and said, okay, based on this, usually around day 4, we're able to figure out what an estimated length of stay was. In general, for patients with a stroke, that's somewhere between 21, 24 days. Obviously, every stroke patient is different and it's going to depend on the person, on their level of motor impairment, on their other impairments. But for about 90% of our patients, it's somewhere between that 21 and 24 day mark. And so once we have that in plan, we'll go ahead, we'll continue doing our treatments. If somewhere around day 10, we're figuring out, so halfway, that patients still look like they're having trouble and it's not likely to have their swallowing be regained where they can safely tolerate an oral diet, we're going to set in motion our plan to figure out having them return to Tufts for a peg tube. And so what it's set up to do is that our rehab colleagues can call to our acute care surgery coordinator at Tufts and they can schedule surgery. The rehab, or the time, that we set for having that surgery be scheduled is within 48 hours. So within 48 hours of the rehab calling our acute care surgery, we will have that patient scheduled for their peg tube, which is why we decided we'd start that somewhere in the middle so that we allow for time and then allow for time on the back end of that. So patients identified as need, we call, rehab calls, we set up that appointment for a day surgery, and the patient is able to come in and have that peg placed and then return to rehab and still have time left in their rehab time so that they're able to have important teaching be done at the rehab with SLP, with their family, with nursing as to how to manage a peg tube, how to manage feeding, rather than having them come, have surgery, have it be a day or two, they end up getting back to rehab, and then it's like, tomorrow you're being discharged home, and we're putting patients in a precarious situation where they're having to deal with this new feeding tube. One of the other things that we put in place that really helps make this process as streamlined and efficient as possible starts actually during the hospitalization. When we know that a patient is going to be discharged with an NG tube or Doboff tube, we have requested that our inpatient neurology team consult the acute care surgery team. This allows for the acute care surgery team to come to meet the patient, to have an idea of that patient. They can do pre-surgical assessments, their H&P, their physical assessment, as well as any blood work that needs to be done, whether that's a type and screen, coagulation studies. It allows for them to get consents, both for anesthesia and for the surgical consent. And it also starts that level of communication between acute care surgery and neurology. As we know, a lot of patients with stroke either are on an anticoagulant or an antithrombotic. Really all people with acute ischemic stroke are. And so question is, when we know a surgery is coming up, what do we all feel comfortable with in terms of holding that and restarting that? And so that allows us to have that conversation sooner rather than later, so that hopefully when the patient's discharged, that plan already exists and can be communicated to the rehab staff. Okay, in the event that Mr. Jones needs a peg tube, and this is going to happen, we would like him to hold his aspirin for 2 days before, and then he's going to come in and then he can restart it immediately after. The great thing about H&Ps and consents is that they're valid for 30 days. And so by having that done during their inpatient hospitalization, it eliminates the need for an additional surgical appointment. So that eliminates another time that the patient needs to come back and have an appointment for an H&P and pre-op evaluation to be done. And instead they just come in once. They come in for their peg tube. That's done, like I said, as a day surgery procedure. So they would come, they would have their peg tube placed. The goal is to have that patient back to rehab within about 4 to 6 hours after peg tube placement. Hopefully it's one of the first cases of the day. They're recovered and then sent right back. And then that way rehab can manage titrating the tube feed, can manage teaching and education, and have sufficient time to be able to do that. So now that we made these plans, how can we implement them? And so a lot of this are things we've already talked about. It was really important for us both at Tufts and at Encompass to create practice guidelines. How is this going to look? How are we going to operationalize this? And then education. So what are all of our key stakeholders? Who are these people across all sites, and how do we educate people? How do we inform people that this is the process we have in place and this is how it works? So some of those important people that we've already kind of talked about would be case managers, physicians, speech and language pathology at Encompass, their staff, as well as their SLP, their pharmacy, their rehab liaison, who's here working with our case managers to be able to admit and figure out who might be a potential good candidate for this program. And then as well as creating those guidelines and pathways and figuring out exactly, like I said, how to operationalize this, how to make this possible. Dan, Teresa, I don't know if you have anything, we'll have them talk about their process a little more in just a second. In terms of the process here at Tufts, anytime we have an acute stroke patient who fails their dysphagia screen, the goal is within 24 hours to have SLP do their more formal evaluation, so their NE2 and FOIS, so that we can take that information, the neurology team can gather the rest of the information for the press and put that in and come up with a plan. By the end, hospital interdisciplinary or bedside rounds on about day 2 of hospitalization, we really want to start that discussion. We want to have our press calc score calculated. We want to start talking about what category do we think people are going to fall into and what would be the best feeding plan for them. And then that can help us guide and inform that decision. If necessary, we would consult acute care surgery and kind of start them on that process. Dan and Teresa are going to tell us a little about what happens on the other side.
Yep, thanks, Kate. So one thing I think that's important to touch on before we get too deep into the process from the rehab perspective is that back when Kate talked about getting stakeholders involved, getting our leadership involved and understanding and knowing what the goals were with these pathways. The elephant in the room sometimes is we know what is right or the best clinical care for the patient, but often we have to think about the payer. And, is this a Medicare patient? Is this a commercial insurance patient? Acute rehab hospitals are paid in a prospective payment system, which is a lump sum system from Medicare. And so when we came to the table to talk about the plan and, how do we reduce length of stay at the acute? How do we get stroke patients started on their rehab course earlier, because all the research says that that's appropriate, but there may be these kind of plan Bs with the Dobhoff and or a G-tube being needed. How do we meet the clinical needs and expectations of what's best for the patient, but looking at the operational needs as well? And so when we got our leadership team involved, this prospective payment system that we're paid on, these procedures end up being at the cost of the rehab hospital. But when we look at the pros and cons and the benefits, we're also reducing possible readmissions. We're having better outcomes in the long run for the patient, and then also looking at reducing 30 and 90-day readmissions and complications after that. So I think that's one important piece that's kind of can be the elephant in the room sometimes, is the payer. The other thing is, as our conversations continue to evolve, and we saw how the team at Tufts was able to mobilize surgery and the ED and all of these other departments to put these really beautiful pathways in place, we started re-looking and evaluating, and we relied heavily on our neurologists and our speech language pathologists, that the thresholds that were decided upon based on the press calc score and clinical judgment, that with these solid pathways in place, we were willing to take even a higher risk than just what some of those thresholds were saying. So we started off this conversation saying, yes, send us the Dobhoff patient that falls into, this category or within these thresholds. But once we saw kind of how proven and solid the pathways were put together, and that relatively easy to implement, then we were able to say from a rehab perspective, you know what, we can take a lot more risk because we have this backup plan in case we need it. So that I think was very interesting and sort of shown the evolution of this discussion and trust, and is really a testament to what the team, Kate and Dr. Leung and the rest of the team at Tufts was able to mobilize all of those other departments to see fit. So from an implementation standpoint for us, the key really is that rehab liaison that we have assigned to Tufts. So we have one liaison. She screens for all of our 5 locations. She has a direct connection to Kate, to the case managers who cover that particular floor at Tufts. And it was also nice because Kate and Dr. Leung did a presentation to the case management department at Tufts to make sure that they understood the pathway, and that really one of the goals in this was being able to help reduce that length of stay and get patients at the right place at the right time. So Kate also mentioned within the pathway, we're doing a lot of pre-evaluation just in case a PEG is ever needed. So the liaison is really sort of owning that, yes, that got done, and did all of that information come to us. So that in the process of just a normal transition to rehab, we get a discharge summary, but the liaison is really reassuring that the speech consult notes, video fluoroscopy results, the surgery consult is given directly to us prior to the patient coming. And then we're also having our pharmacy do a medication administration review, just as a double check that if that source, if that Dobhoff were to be dislodged, do we have a way to administer the medication that the patient really needs until we can reassert it ourselves or get them back to the ED to get that reinserted. So that's really a critical piece of that connection between both organizations. And then really from there, the admitting office is making sure the entire disciplinary team here is aware that this is a stroke pathway patient. And we have then taken those pathways and have done education with our medical director, our neurologists, the entire medical staff. We have night call physicians. So if this were to happen at night, nursing supervision, nurse managers, all the SLPs, but also the unit coordinators, because the unit coordinators in our organization would be really the driver of helping set up transportation to get back to the ED or to the appointment, maybe the ones calling to initiate the surgery schedule. So, we really had to look closely at all of the people on our team that touch this patient and that can help facilitate what the next steps may be. And we really had to look at it as, a stroke patient comes to us, we follow our normal plan. Speech sees a dysphagia patient daily. They're constantly evaluating their swallow, looking to improve. It's just that this patient happens to come with a new source of nutrition. And so our dietary and nutrition staff are also aware. And with the daily speech training, we can do modified barium swallows as indicated. We're going to introduce PO and then work to get that NG tube removed and progress that patient along. We had to look at our implementation process too of the what ifs. So what if this happens? How do we act and respond timely for that patient? And again, the timeliness was really important when establishing the pathway. We know that often if we send a patient, just experience has told us, if we send a patient back to an acute hospital, regardless of the amount of communication that's occurred from our admitting office, our liaisons, and or physician to physician, very quickly can the patient get rerouted and just get admitted in the ED. And then, we sort of lose that patient and start all over again, where these pathways were very sensitive to those turnaround times, clear communication that the patient's coming for this specific need, and that, we made sure that clinically, everything that would be done post-surgery or post-procedure, that we were able to handle and take on, that we didn't need the patient to stay until their first tube feeding was run, So that, as Dan alluded to earlier too, just reassuring clinical competencies, not just on one unit where most of our stroke patients go, but we're talking about 5 locations, 24 hours a day. So just making sure that our staff competencies were up to snuff as well. The other thing I will add before I sort of hand the microphone back over to is, Kate pointed out the press calculator being, specific to acute ischemic stroke. And I'm not here to question or doubt the research or the paper, because you do have to identify very specific who this is going to work for and who the press calculator isn't going to work for. But again, having these pathways in place as a backup plan for us as rehab providers really sort of allows us to think about, okay, with these pathways in place, with or without a press calculator, do we look at SLP and neurology's assessment of swallow and experience and recommendations for a hemorrhagic stroke patient that maybe we would take with an NG tube? Because again, we'll continue to treat their impairments, and we have a backup plan should their swallow not recover in rehab. So it sort of opens the door for other discussion, which I think will be sort of in the next couple of slides.
Thanks, Teresa. All excellent points. And then for our data collection, like any good quality improvement project we talked about, it's important to collect data. And so we did. We collected data on patients admitted with acute ischemic stroke who failed their dysphagia screen into two groups. So one group being the pre-data before we initiated this nutritional support pathways and use of the press, and then post-data after we admitted that. And so in terms of primary outcomes as of right now, two focus areas have been the time to decision for PEG tube placement. So meaning how long after their admission to documentation or to the plan of consulting surgery and proceeding forward with the PEG, as well as looking at length of stay for those patients. And I'm going to actually be a bit of a tease here. I'm going to make you all wait. We do have some preliminary data, but not to be a total plug for AHA, ASA, but we will be sharing this data in our first presentation as part of a late breaking science abstract at the International Stroke Conference next week. So in the age of Netflix, where your next episode is always available, I'm going to go back old school to TV, and you're going to have to wait a week to find out what happens next. But that will be coming, and you'll be able to hear more about that. As kind of next steps, too, we're going to continue our data collection, increasing the size of our data set, looking at possible new outcomes or new things we can measure, and continue to look at other ways that the other things that affect the PRELS, how other clinical characteristics affect that outcome. So for example, as we said, the NIH stroke scale is part of the calculation, but what about those patients who are admitted with an NIH stroke scale of 26? So super high, and then they undergo emergent treatment, TPA and or endovascular therapy, and then their NIH stroke scale is a 4, or even lower post-treatment. How does that affect the estimation of the duration of their dysphagia and ultimately the PRESS score and how we evaluate what their feeding plan should be? It's also been part of the process to look at different limitations as we started this project and as we continue going forward. We started this and have continued it kind of during the COVID pandemic. And ultimately, I think that's influenced, it hasn't necessarily at Tufts changed the number of patients we've treated, but it's definitely, I think, had an impact on treatment decisions in terms of ICU bed and bed availability at the hospital, as well as rehab bed availability, and just in general overall length of stay as we're making sure that patients are, safe. And some patients ultimately, I think, have altered or changed maybe what their feeding plan decision or what they would feel comfortable with because they want to go home. They don't want to be in a facility, no matter how safe we're able to keep them. And so how has that affected this process? Working on continuing our process improvements, so always thinking about how can we make this better. And I think hopefully it's obvious that we work well together. And one thing that I think that has been a big strength for us is our communication and knowing that if problems do occur, we hopefully can address these in real time and be able to fix them as soon as possible and take a step back and look, how do we prevent this from happening in the future? In terms of data collection, our plan is to also expand that data collection at the rehab facility. So look at more post-acute care outcomes, not just acute care outcomes. So things such as like the 90-day modified Rankin scale, the timing when people are able to initiate that oral intake if they're discharged with a DOB-OFF or NG. Looking at some quality of life scales for patients with this NG tube and during their rehab stay and after that tube has been put out, or for people who ultimately go down that pathway of an early PEG. There's a potential for future collaborations with this project in general. Are other acute care hospitals willing to work with us and with the Encompass and other rehabilitation hospitals? If this is a best practice, and hopefully we're able to prove that this is a best practice and process and ultimately leads to better care, how can we share this and have other patients and other centers benefit from that? In terms of publications and presentations, as I said, we'll be presenting at ISC next year, and currently we're working on publishing and writing up a manuscript to be in an academic journal. So hopefully that'll be coming out in the next year or so, or hopefully sooner than that. And thank you. I'm sorry, I know we went over a little time. Apparently we had a lot to talk about, but thank you so much for your attention. And I will turn it over to any questions and any information. I'll be sending our slides, so you'll be able to have the PDF as well as Teresa Dan's and my contact information.
Thank you all. I'm going to go ahead and